Just give a brief introduction of myself. My name is Suhail Sharif. I'm a surgical oncologist. I did my surgical training in Chicago, and afterwards I did a year of research in Chicago as well, basically looking at omega-3 fatty acids and its anti-tumor effects, and worked with a lot of rats in those situations at that time actually. And we basically induced sarcoma on rats, and then we gave them omega-3 fatty acids, and we gave some COX-2 inhibitors and looked at the effects of all these on cancers. So that did that for a year, and afterwards I went to Ohio State for fellowship, and for 2 years of fellowship, and then subsequently I just wanted to move to a warmer climate, and here I am. It's been about 7 years since I moved here, and it's been great. And obviously I'd like to thank Dr. Crawford and the Forward Surgical Society for giving me the opportunity to talk about a very interesting type of cancer here. And I'm going to specifically concentrate on just lymph node harvesting, but at the same time I'll talk a little bit more about gastric cancers in general and how do we treat them in general, so because we have a lot of students here, and then concentrate on something very specific that is a issue that you see in our surgical society and just the ways that we can rectify it and correct it. So having said that, let's move forward here. Clicker. Again, my disclaimers, I have nothing to disclose. The objectives just here is that we're going to use some NCCN guidelines. NCCN are just National Comprehensive Cancer Network guidelines that we use as clinicians to treat cancer surgeries and so forth. And we're just going to describe the guidelines for gastric cancers. We're going to use, again, evidence-based medicine to see what the workup and treatment are for gastric cancers, and also look at how can we optimize lymph node harvesting, and why is this a problem, and how significant of a problem it is. We'll look at that, and also look at roles of just minimally invasive surgery. Just now in this era of robotic surgery and laparoscopic surgeries and so forth, we want to know, is gastrectomy appropriate for these procedures as well. So before we get started, this was a slide that I saw last year when one of the presenters from Forward Surgical Society presented, and I just love this slide, and I just had to search it and put it up here because it just basically tells you the attention span of the audience in relationship to time. So you can see that after like 10-15 minutes I'm going to lose a lot of you, so I'm going to try to keep it interesting and can I keep you entertained as well. So for all the students here, any historical buffs, could you tell me who said this famous quote here? Ambition is never content even in the summit of greatness. Any guesses? It is this gentleman right here, Napoleon. So Napoleon mentioned this statement, and the reason why I bring it up is the fact that recent data has suggested that actually he died of gastric cancer. Why is gastric cancer so important? Worldwide, if you look at it, it's the second most common cause of cancer-related death, actually. So it's very significant worldwide. In the U.S. itself, it is the 15th most common cancer that you see. And then it's estimated about 25,000 cases in 2015. Of those, almost 10 to 12,000 of these patients die every year from gastric cancer. And if you look at the demographics here, it's a little bit more common on males, a little bit more common on African Americans, and so forth. The other thing you see here is the fact that the median age for gastric cancers is more in the elderly population. Median age is about 69, but nevertheless you still see gastric cancers in earlier ages as well, in the 30s and 40s as well. And here again, about 25,000 cases of gastric cancer in 2015. And what's important here is you can see the survival. Survival for gastric cancer, 5 years across the board, regardless of what stage it is about 30%. And if you break it down even further to their relative staging, you can see that there's a significant drop depending on what staging of cancer these are. So gastric cancers in general, if you look at it, they're confined, if a third of them are confined only to the stomach, and a third of them are confined where they're in the stomach and spread to the lymph nodes, and a third of them at presentation, these are all at presentation, have metastases. So if you see that the gastric cancer is confined only to the stomach, the survival is still only about 65%. That is very low. And if it has spread to the lymph nodes, then there's a 30% drop in there, and it's almost like down to 30% 5-year survival. And now if it's spread to distant organs, then you're down to basically 5% survival. What that basically means is the fact that I don't know if this pointer works, but is the fact that if you have 100 patients or 100 people, only 29 of them will survive after 5 years. And especially in surgery or even in medical literature, we keep 5 years as a benchmark to give us an idea about exactly what the figures are going to be, so that way we have a consensus on how everyone can talk and so forth. So that's the reason why we use 5 years. Doesn't mean that that's all they have to live for, but it's just a benchmark so that we can use and give us an idea about their survival for all the different types of cancers. All right, so if you break it down even further into specific stages, which we'll look at it a little bit more, but just so you know, just the observed survival goes anywhere from 70% to all the way down to like 4 or 5% depending on the stages. And now here, what is important here is the fact that in 1975, you can see that the 5-year survival is 15%, and it has almost doubled in the last 30 years. So that is significant, but at the same time, not extensively. And I'll talk about exactly why that is the case as well. Now, if you look at the clinical manifestations, the early signs of gastric cancers are usually asymptomatic. Most of the time they present with basically no significant symptoms, maybe some vague epigastric pain. They have some nausea, vomiting, some anorexia, some weight loss, and then your regular doctor does the workup and can do some endoscopies and refer you to a GI doctor, and that's when they might see some ulceration in the stomach and get a biopsy, and next thing you know, you have gastric cancer. And the later findings would be is where you start having pain and you start having more discomfort, start having more extensive weight loss and so forth. And that's when you know the gastric cancer is going to be even more advanced. So the fact that you can identify them early is probably one of the reasons why most of these cancers present later on in stages. Because when we looked at the previous slide here, you saw that only about a third are confined to the stomach, which means 2/3 of them have either spread to the lymph nodes or already spread to different organs. And then any risk factors for gastric cancers. There are certain specific risk factors like familial adenomatous polyposis that has a defined risk factor for gastric cancer. You also have gastric adenomas or any kind of biopsies that show high-grade dysplasias, and you can just go all the way down. Even excess alcohol ingestion. Oh my God, what can I not say this word? Ingestion can also cause gastric cancer. Looking at the NCCN guideline, what I want you to concentrate on just the column on the right, which just tells you the basic workup for gastric cancer. This is the NCCN guideline again from this year that tells you that anyone who has gastric cancer, they should undergo a upper GI endoscopy to get the biopsy, and they should get a CT scan of the chest, abdomen, and pelvis, and also should get a PET scan as well. And then you can follow the clinical status and the evaluations and the treatment that is listed here, which I will talk a little bit more in the next slides here. So again, the diagnostic workup, anyone who presents with suspicious lesions or suspicious clinical presentation for gastric cancer, what you do is in here they talk about like getting a double contrast barium swallow, but ideally anyone who has any of these symptoms, we kind of just skip and go directly to an endoscopy. You refer them to a GI doctor, they get an endoscopy done, they get a biopsy, and depending on the biopsy we follow what we talked about in the previous slide. They get a CT scan of the chest, abdomen, and pelvis, and they get a PET scan to be able to stage them. I know there are a lot of students here, so just to kind of recap a little bit about cancers in general. Whenever anyone gets diagnosed with cancer, the most important thing that we want to do is stage these cancers. The reason why we stage cancers is so that way we can come up with a treatment plan for them, and also it gives us an idea about their prognosis. So because of these two reasons, that's the reason why we stage them. And again, staging involves what we use is the TNM classification that has to do with where the tumor is in the primary organ, and number 2 is to see if it has spread to any lymph nodes, and number 3 if it has spread to any other organs, and so forth. So that's the reason why we use that TNM classifications, and the way we accomplish and get all this information is through the CAT scan and PET scan and endoscopies and endoscopic ultrasound and so forth. Alright, next slide here. So once we get all this information, then we use this table, the TNM classification table, and it tells you where you fit each of them in, and according to where you fit them in, you'll be able to come up with an appropriate stage. What's important here is the fact that if you look at the regional lymph nodes, you see that the regional lymph nodes for gastric cancers are broken down very specific to the amount of lymph nodes that are involved with cancer. So for example, you need to have at least 15 lymph nodes to be able to accurately stage these patients. If you do not have 15 lymph nodes, then there's no way for you to know if this one has, if this patient has an N2 disease or N3 disease or so forth, if you have less than 15 lymph nodes. Because for you to be able to know which N a patient has, you need to have at least 15 lymph nodes. And I want to just stress on that point because I'll get back to this in the future. And according to the TNM classification that you looked here, you can just plug them into this thing and they'll give you the stage. And once you know the stage of the cancer, then you'll be able to come up with appropriate treatment. And what kind of treatments do you use? That's when we go back again, use the guideline according to the NCCN criteria, and then we come up with our treatment plan. What it's telling you here is the fact that anything that is just confined to just the top layer of involvement of the stomach, you can basically just go directly and do surgery to them. It's something called an endoscopic mucosal resection, where the GI doctors can just go in with their scope and just take out that tumor. But anything that's more infiltrating than just the mucosal layer of the stomach, that's when you'll have to do multimodality treatment. And what you're seeing here is the fact that the recommended treatment, I wish my pointer worked here. The recommended treatment here is that is perioperative chemotherapy. Perioperative chemotherapy means you get some chemotherapy before surgery, you undergo surgery, and then depending on what the outcomes of surgery are, they get more chemotherapy afterwards. And that is a Category 1 recommendation as far as NCCN guideline goes. Category 1 meaning there's basically consensus or census from all the physicians who are participating in this that this is the optimal treatment for these cancers and so forth. And if they cannot undergo chemotherapy for any reason, if they have an obstruction of the gastric cancer, or if they're bleeding, or if there's a perforation, then you go directly to surgery. Other than that, if they just come up with a routine case of gastric cancer, then they should undergo chemotherapy first, and then they can undergo surgery and then more chemo afterwards. The reason for that is this is a MAGIC trial that was done in England, and this basically gives you the 3 chemotherapy drugs here that you see: ECF, epirubicin, cisplatin, and 5-FU. You give 3 cycles of this before surgery, they undergo surgery, and 3 more cycles afterwards. And the MAGIC trial, what it said was, again, randomizing these patients into surgery or surgery with perioperative chemotherapy, and what they see is that there is a progression-free survival benefit. Again, we take the mark as 60 months or 5 years, and you can see that that just going to surgery, the progression-free survival was basically 15%, and then you're just jumping up to 32%, almost doubling the survival just by giving them some perioperative chemotherapy. Now, if you look at their overall survival with the MAGIC trial, same thing. You have a 18-month survival with just surgery, and then you're basically doubling to 38 months if you give them perioperative chemotherapy. So that was the reason why the NCCN guidelines recommends that you should undergo perioperative chemotherapy for gastric cancer. All right, so once we do they do chemotherapy, then they have surgery, and they have more chemotherapy, then the question becomes is, what do you do after surgery? What if there's complete R0, R1, R2 has to do with the extent of your resection. Okay. Basically what it tells you is the fact that if you have an R0 resection, it means that you have completely removed the tumor and you have not left any tumor behind. R1 has to do with where you have microscopic tumor that you might have left behind because it was just too big. And R2 is where there's macroscopic tumor left behind, this gross tumor left behind because it might have been stuck to the retroperitoneum, might have been stuck to the pancreas that you can't get out, and so forth. So it's just basically telling you that if you have all the tumor out and if the lymph nodes are negative, then you're basically done. But if you have lymph nodes that are positive, then you might need to give them chemotherapy. And that's important as well. So you need to know if the lymph nodes are positive for them to get any further treatment. And as far as R1 and R2 goes, you can see that they need chemoradiation as well for local control. So Napoleon's gastric cancer was staged as a T3N1 lesion. Now, the reason why I just gave you this brief background is that as surgeons, we have a tremendous responsibility in terms of providing appropriate care and also providing good quality care as well. And this goes all the way back to when it was basically when it began. And what you're seeing is the fact that we came up with new developments and new societies and new organizations to be able to assess and to be able to put this all together. Well, a few of the things that we came up with as American College of Surgeons is the Commission on Cancer that was created in 1922. And then later on, the National Cancer Database was created in 1988. And then you recently have the Quality Improvement Program that was in 2013. All of this were created so that way we can assess and we can come up with a idea about exactly how well are we doing to other surgeons. So that way we can compare, we can learn, we can figure out how else we can improve and so forth. So what we talk about is the fact that if you look at this, the Commission on Cancer, you see that this was created in 1922, and this is basically standards of ensuring quality, multidisciplinary, and comprehensive cancer care in a healthcare settings. And again, this is where they set up the guidelines that you need in terms of for all the programs to follow and so forth. And now you can see that the Commission on Cancer, it gives you accreditations to all the different programs. There are about 1,500 programs in the U.S. In Texas itself, there's about 87 programs. So this is basically, it's a pretty good honor for a hospital to have when they have been accredited by the Committee on Cancer, because that gives you the seal of approval that this is a program that follows the guidelines as it was written. Going back to the National Cancer Database, this is a database again that all these hospitals, they basically provide this database to the NCDB, and what they do is they accrue all these patients, and then through these patients they can compare and contrast all the different hospitals. They can set guidelines, they can see how your hospital is doing and compared to the other hospitals, not only regionally but also nationally as well. And you can see here that it captures almost 70% of all newly diagnosed cancer in the whole US. So this is a pretty powerful database that you have, and that we can use as well and compare and so forth. And I'll show you some information about that too. And again, the other stuff is the Quality Improvement Program that individual COC programs come up with. And again, looking at the same thing, basically just quality measures that we can use for all different cancers and seeing how we compare with each other programs and so forth. So for gastric cancer, one of the quality improvement measures that we see here is identifying at least 15 regional lymph nodes are removed during surgery and examining them. The fact of the matter is that these are just numbers from local hospitals here that I put up here. So you can see that the benchmark is about 80%, but you can see that we fall well short of that in certain hospitals here. This is just one hospital, and I just want to put up another hospital here as well. Again, same thing. So regardless of which institution you're going to, you'll see that these numbers are actually pretty low. That even the benchmark of 80%, where 80% of the cases that undergo gastrectomy should have at least 15 lymph nodes, we're almost nowhere close to that. We're almost like maybe half that number. And again, same thing, like in between 25% to 50% range. And you might wonder, is this something that is just Fort Worth problem, or is it something that is much bigger than that? And this is basically what it tells you right here. Again, in this one, it compares the institutions here to the region, to the state, and also nationally. And what you can see here is the fact that in the state itself, the percentage of getting 15 lymph nodes is still very low. It's still about 45%. And if you look at it in all COC programs throughout the United States, that is still only about 50%. So a lot of the programs are actually, you can see majority of these programs do not even qualify to satisfy the need of having 15 lymph nodes assessed. And why is this significant? Because early on we saw the fact that how well the survivals are for gastric cancers. The survival even for gastric cancers that are confined to the stomach is only 60%. So the fact is that how well are we doing in terms of identifying gastric cancers, and how well are we doing in terms of staging gastric cancers? That seems to be the biggest issue here. And they have actually done studies as well. Again, the AJCC has done studies, and what they have said is the fact that surgeons, when they undergo when they do gastrectomies, they say that only about 31% of surgically resected specimens have adequate gastric lymph node harvesting for them to be able to stage them. So which means almost 70% of the gastrectomies that are done in the US more or less are inappropriately staged. And again, this is also from the National Cancer Database. They also came up with a report that said that only about 18% of US patients have greater than 15 lymph nodes that get harvested, which means 78% of the patients that undergo gastrectomies, more or less, we do not have adequate lymph nodes that we can harvest. And because of that, maybe we're inappropriately staging these patients, and because of that might be one of the reasons why they probably have much poor prognosis. Because as we talked about, anyone that where the lymph nodes, where cancer has not spread to the lymph nodes, they're considered to be early stage cancers or just regional gastric cancers, and their survival, you expect them to be 65%. But if it has already spread to the lymph nodes, then you expect their survival is about 30%. So if you have someone where you might have taken maybe 7 or 10 lymph nodes, and then all the lymph nodes are negative, you might suspect that, you know what, they do not have any lymph node spread, so you're suspecting them to just have local disease. But then you see that their 5-year survival is in the range of 40% or so forth. And the reason for that, again, is because we have inappropriately staged these patients, considering them that they do not have any lymph node spread, while in fact that majority of these patients, they probably have lymph node spread. And the question after this, it becomes why? What is the reason behind this? Why are we doing so poorly in harvesting lymph nodes? And what can we do to better this? The reason for this is actually anatomical. The way that gastric cancer is and the way that we harvest lymph nodes have to do with where we get the lymph nodes from. So lymph nodes for stomach are basically located around the vascular blood supply, just like any other lymph nodes in the body. And what you're seeing is the fact that they are all defined according to the stations that they are in. There are about 16 total stations of lymph nodes around the stomach, and 6 of them are right next to the stomach, and afterwards the 5 of them, they're around the major blood vessels, which is the celiac axis, and around those blood vessels is you have about 11 or so that are more or less that you can grab and get, and the rest of them, like stations 12 to 16, are a little bit more away from the stomach and so forth. That might be a little bit more challenging and tricky to get. So for our intents and purposes, we're just going to talk about just these 11 lymph nodes, 6 of them around the stomach and 5 of them just slightly away from the stomach. The reason why that is significant is because there's actually specific procedures that state which lymph nodes you take out will dictate what type of procedure you do. For example, if you take out only the lymph nodes that are around the stomach, that's considered a D1 lymphadenectomy. And if you take out lymph nodes that are around the major axis, like the celiac axis and all its lymph nodes, those are considered D2 lymphadenectomy. So for D1 lymphadenectomy, you're taking out 6 stations. For D2 lymphadenectomy, you're taking out 11 stations. Okay, so that's point number 1. Point number 2 is the fact that is the location of the lymph node significant, meaning do you need to specify where you have gotten the lymph node to be able to say that that this cancer has spread to that lymph node or so forth, or does it not make any difference? So again, studies have shown that in fact, if you look at it, it does not matter where the lymph nodes are from. As long as you get 15 lymph nodes, you're good. For lung cancer, for example, it's important to know which station the lymph nodes are from. But for gastric cancer, that is not that important. All you need to do is have 15 lymph nodes, so that way you can come up with an adequate staging, rather than knowing if they're coming from station 1 or station 4 or station 11 or so forth. So, but as long as you can get 15 lymph nodes from any of these stations, you're good. So then the question is that what is the normal quantity of lymph nodes in all these different stations? Maybe that's probably the reason why we're not getting enough lymph nodes. And what you're seeing here is the fact that, again, there have been studies that have done that looked at this in cadavers and so forth. And what you see is the fact that the average number of lymph nodes in D1 stations, which are stations from 1 to 6, are only about 15. And for D2, there's 27 lymph nodes in that station. So, and D3, which is all the other stations that we talked about from 12 to 16, they're about 43. So as you get away from the stomach, you get to have more lymph nodes and so forth. So if your goal is to get 15 lymph nodes, And if there are more or less only 15 lymph nodes around the stomach, that is going to be quite a challenge, because you literally have to get every single lymph node around the stomach, and that always is very tricky. So that's the reason why, if you want to get at least 15 lymph nodes, you might have to just venture a little bit away from the stomach in order to get some additional lymph nodes to make sure you're able to satisfy that 15 lymph node mark. And so how do you harvest this 15 lymph nodes? The way you harvest this is that Japan has a very, very high incidence of gastric cancer. So we sometimes look into the Japanese studies to see what they're doing, and then being able to implement that in our treatment as well. So in this study, what they do is they basically just do extended lymphadenectomy. They just go and take out more lymph nodes and then do what we call that D2 lymphadenectomy. So in that way, they have close to 43 lymph nodes to work with, so they can make sure they can get at least 15 of those lymph nodes. And what you're seeing is the fact that by doing the extended lymphadenectomy, their overall survival is actually much better. Like we talked about in the US, the 5-year survival is what? 30%. And what you're seeing in Japan is the fact that their 5-year survival is almost twice as much. Okay? And the reason for that is, again, because of the fact that they do some extended lymphadenectomy studies as well. So then the question becomes is, why don't we do this? I mean, if there's clear data from Japan that tells us that this is the case, now why can't we do the same thing? The reason is because there are a couple of other studies that were non-Japanese that did the same thing. They looked at gastric cancers that were resectable, and they randomized and split them into some that undergo D1 lymphadenectomy, stations 1 to 6, and D2, which is stations 1 through 11. And what you see in here is the fact that they're basically, the survivals are absolutely the same. There was no different that you see. And you might say, like, I mean, that's just one study. What about something else? And I'll come up with another study as well. But what else it saw was that in this Dutch trial is the fact that the degree, your mortality almost doubled, in these patients who undergo D2 lymphadenectomy. And they said that could be correlated to the fact that when you're doing this D2 lymphadenectomy, you're actually having a much higher chance of doing a distal pancreatectomy and splenectomy as well. And the reason for that is just, again, anatomical, because the fact is that when you're doing the D2 lymphadenectomy, you're taking out all the lymph nodes that are around the splenic artery, you're taking out all the lymph nodes that are around the celiac axis, and you're taking out all the lymph nodes that are around the gastric vessels and also the common hepatic vessels and so forth. And the certain other stations, like stations 10 and 11, they're basically around the splenic hilum. And when you're trying to maneuver and take out those lymph nodes, you're actually unintentionally damaging the splenic artery, and that basically leads you to undergo a splenectomy, and at the same time you end up doing a distal pancreatectomy as well. And that's the reason why you see that in the Dutch trial there was a 67% chance of having a distal pancreatectomy splenectomy if you're doing a D2 lymphadenectomy as compared to D1. And then you can see that the mortality is also twice as much on these patients who have undergone a distal pancreatectomy and splenectomy as compared to not having undergone that. So there's another trial that looked at the same thing, a Medical Research Council lymphadenectomy trial, again, splitting the patients into D1 lymphadenectomy and D2 lymphadenectomy. And what you're seeing here is the fact that the same thing. There was absolutely no survival advantage of doing a D2 lymphadenectomy in 5 years. And what they saw was absolutely the same thing as well. The fact that there was almost twice as likelihood of doing a distal pancreatectomy splenectomy as compared to the D1, and then the mortality was also twice. So because of these two studies is why in the US we generally just do a D1 lymphadenectomy rather than a D2. Now, is there a way that's can we do something where we can balance these two treatments, balance the way that the Japanese do the study, and then balance the way that we do the surgery? So what you can see here is one of the ways that we can accomplish this is trying to come up with basically try to come up with a way we can compromise between the two. Okay, being able to do a little bit more than a D1, but not as much as a D2. So a compromise, and I'll talk about how you're going to do that. One way of accomplishing this is basically trying to be a little bit more aggressive with our surgical resections. What you see is the fact that if you do have a gastric cancer that is more in the proximal stomach, it's recommended to actually do a total gastrectomy, because if you see where are the lymph nodes uh, for the lymph nodes around the stomach are basically in the lesser curvature and also in the greater curvature. And for you to get all those lymph nodes, you basically have to take out, devascularize the entire stomach, and that'll be the only way for you to get all those lymph nodes. And sometimes, you know, we're just not very aggressive in terms of our surgical treatment. If you have a gastric cancer that is very small, you might just go ahead and do a partial gastrectomy and not really skeletonize the entire stomach, and through that we're not able to get all the 15 lymph nodes. And the same thing goes if you have a gastric cancer in the distal part of the stomach. We do what we call a subtotal gastrectomy, where you try to leave maybe 10-15% of the proximal stomach and take the rest of the stomach out. And by doing these, we'll be able to basically get enough lymph node harvesting that you can at least satisfy the 15 lymph nodes. And it just talks about like different reconstructions you can do. When you do a total gastrectomy, you do a Roux-en-Y esophagojejunostomy. And if you do a subtotal gastrectomy, you can do either a B2 gastrojejunostomy or Roux-en-Y gastrojejunostomy. And just tell you that the standard extent of surgical resection, if it's a middle or distal, to do a subtotal gastrectomy, almost a complete subtotal gastrectomy, and if it's proximal or around the GE junction, then you should do a total gastrectomy. And the reason for that is here, this is a very great table here. It tells you that you might think this tumor is basically microscopic, or that it was just picked up incidentally during a endoscopy. And what you see is that a submucosal lesion that you can't even palpate, you can't even feel, has almost a 25% chance of having lymph node spread. Meaning that just a small little submucosal lesion, you still might have to do a subtotal gastrectomy so you can get all the 15 lymph nodes to be able to accurately stage them. And maybe that's one of the reasons why we're not able to accurately stage this patient, is because we're not able to be more aggressive with our surgical resection. All right. Moving forward, what about the role of minimally invasive surgery? Can you accomplish what we need to do from an oncological standpoint with just minimally invasive surgery? And what you see is the fact that, again, there have been a lot of randomized trials and comparative studies that look at laparoscopic gastrectomies with open gastrectomies. And what they see is the fact that, that there is actually no difference if you do these surgeries laparoscopically or open in terms of their survival. And also what you see here is, again, in terms of the mortality as well. Again, you can see that the mortality here, there's no statistical significance as well. And again, laparoscopic versus open, you see that the number of lymph nodes that were harvested were also more or less the same too. And more of meta-analysis of all these patients look at the same thing, that there was no difference in survival between laparoscopic case or an open case. And more importantly, if you look at this meta-analysis as well, you can see that specifically the column, that's the fourth one, the number of retrieved lymph nodes, they're more or less the same as well if you do it laparoscopically or open. The only thing that's important is the fact that the type of surgery that you do. You know, let it be laparoscopic, robotic, or so. You want to make sure that you're still doing an oncological resection regardless of the size of your incision. You still want to be able to do a subtotal gastrectomy or a total gastrectomy. Make sure you're able to harvest at least 15 lymph nodes either way, so that way you can satisfy so that way you can satisfy and be able to get an appropriate staging. So how can we improve lymph node harvesting? I mean, there are methods that pathologists can use as well. Pathologists typically use formalin, and you can see that if they use some clearing solutions, these can detect lymph nodes that are more like much smaller, that you might think they're really nothing, they're just incidental, and being able to get more lymph nodes. And certain other thing is utilizing sentinel lymph node sampling, or maybe using some dye studies and so forth. Here's one paper that looked at basically using methylene blue during surgery and being able to help with identifying lymph nodes that the pathologist can look at it. And here's just a picture of just exactly how injecting methylene blue around your cancer or around the stomach will help identify the lymph nodes that are around the stomach. And then this way that the pathologist can concentrate on that area and being able to pick up these lymph nodes. Again, these lymph nodes are very small, very tiny, maybe even a few millimeters that the pathologist might just discard, but those are also significant from a staging standpoint. And again, this is basically looks at the amount of the number of harvested lymph nodes if you do use methylene blue as versus not using methylene blue. And other ways that we can improve lymph node harvesting is for surgeons is just to perform aggressive surgery. Maybe do a lymphadenectomy with splenic preservation. Rather than you should be able to get all the 6 stations that is around the stomach, but beyond that, rather than getting station 7 all the way up to 11, 10, and 11, maybe spare station 10, which is around the splenic around the splenic hilum and the tail of the pancreas. Maybe spare that so you're not damaging the splenic artery, and then being able to go after stations 7, 8, or 9, and being able to get at least those much lymph nodes. So that's basically one of the things I wanted to talk about, was just to give you a brief recap on gastric cancers, and also mention that that in terms of gastric cancer poor survival, there might be a link between the amount of lymph nodes that we're harvesting to the type of procedures that we're doing, and a potential way that we can probably improve that would be just trying to do a more of an aggressive surgical approach, and being vigilant of the fact that you need these 15 lymph nodes. And it is not a problem that is only a Fort Worth problem, but it is a not only a Texas problem, but it is a nationwide problem that I believe needs some solution. Thank you guys, and open for any questions. Should we put them up actually? Where is that actually?
So Hal, thank you very much. At this point, we're going to unmute our remote sites in Eastland, Decatur, and Palo Pinto. Everybody's still there. Nobody's gone to sleep or gone home. So we're going to open up the session for questions. Does anybody in the audience here? Whoop! There's already a couple of hands going up. If you have a question out in Candace, Tom, anybody out in Eastland have a question? Raise your hand. There's one here in the audience right now. We'll have the speaker repeat the question so you can hear it well out there. Dr. Ziegler?
Good question. So the question was, what is the role of diagnostic laparoscopy for gastric cancers? Actually, we've been burnt. I should say I've been burned a couple of times as well with the same way, and I think I presented some cases in tumor board as well. So where you think that we have good CT scans, good conventional CT scans, PET scans, endoscopic ultrasounds, and so forth that show that everything is even confined to the stomach or maybe regional lymph nodes. But then when you go them for a gastrectomy, that's when you see that they actually do have carcinomatosis. And most of the time, carcinomatosis lesions are very, very small. They're the size of a sprinkle, like a millimeter or two, just kind of sprinkled all over your belly. And regardless of what scanner you have, there's no way you'll be able to pick those up. They could be peppered around the liver or peppered around just the abdominal cavity and the peritoneum and so forth. And unless I think you physically take a look, you're not going to be able to identify them. And I think I have actually just changed the way that I treat these as well, just because of the amount or the percentage of positive diagnostic laparoscopies you do. And because of that, like when they most of the time these patients are going to have at least greater than a T2 gastric cancer. So most of the time these patients are going to require neoadjuvant chemotherapy. So what I do is just do a diagnostic laparoscopy at the time I put a port in them, so that way we can accurately stage them. Because otherwise, you're convince the patient that that their stage is early, that you can help them out, and then you build them up, and then they just undergo through chemotherapy rather than maybe going through something more aggressive chemotherapy. And when you undergo surgery, and you have, as surgeons as well, we block off time for whatever 3 hours or so trying to do a gastrectomy, and which is done in 5 minutes now because you found some positive stuff and so forth. So I think that is going to be a part of the guideline as well, where diagnostic laparoscopy, I believe, absolutely is indicated, and it should probably be done in an earlier stage, so that way we can, when you come back for a definitive gastrectomy, then you're not surprised. And I believe most of the cancer centers like Memorial and MD, they do that in a different setting, just like for pancreatic cancer as well. They do a diagnostic laparoscopy in a different setting than they do a gastrectomy or pancreatectomy. No, sir. The question was. Exactly, exactly. Yes. The question was, would you do anything more aggressive, like getting some lymph nodes at the time of the diagnostic laparoscopy? The answer is no. At that point, all you want to make sure is they do not have stage 4 disease, that they do not have carcinomatosis or anything, anything else that is going to prevent you from undergoing a gastrectomy. The question was, how accurate is PET scan preoperatively for perigastric lymph nodes? I think PET scans in general are not that accurate for regional lymph nodes because majority of the time, because there's so much more activity in the primary tumor that's right next to it, that might just shadow over some of the other positive structures around it. So I think a PET scan is probably more helpful for more like stage 4 disease, honestly, than for regional lymph nodes and so forth. So, and even PET scans in general, they do not tell you how many lymph nodes are positive either, so that doesn't really help much. And I mean, endoscopic ultrasound is pretty good in terms of identifying regional lymph nodes. It's recommended that typically when the GI endoscopist does an endoscopic ultrasound, they will biopsy regional lymph nodes as well. But I still think that the best way would be is to do a diagnostic laparoscopy. And at the same time, you can do some peritoneal washings as well, and I typically do that as well to pick up any floating cells in the peritoneum.
I've got a question there, sir.
Yep.
When you're doing a total gastrectomy or a subtotal gastrectomy for gastric cancer, are you always doing a radical omentectomy as well? I mean, is that, will you get more nodes if you take out the entire omentum?
I do an omentectomy, but most of the lymph nodes are actually around the vasculature that's around the stomach. So by doing an omentectomy, you're really not getting any additional lymph nodes. You're actually, I mean, it's recommended to clear out as well because you might have those tumor deposits that might be in the omentum that you might miss out and so forth. So by doing an omentectomy, you can probably pick those up. But in terms of increasing your lymph node harvesting, that's typically not the case. Absolutely, absolutely. The question was, is it possible that the Japanese have a different tumor biology than we do here? Yes, that is absolutely true. Because I think even Japanese folks as well, when they come here and they try to replicate it, you see that that the data that they come up with is more similar to the U.S. studies than Japanese studies. The question is for colon cancer, there might be a possibility where the number of lymph nodes that we need to harvest can go up from 12%, from that's needed for 12 to up to maybe 30 or so. The question is that for gastric cancers, the reason we're getting 15 lymph nodes, is it just for staging purposes or is there an effect in its survival? I think there is absolutely an effect in its survival. The fact of the matter is that because we're not getting 15 lymph nodes is probably the reason why our staging, or not our staging, the survival is so poor. And I think if we have consistent data that says that that if you get at least 15 lymph nodes, and then you can compare the same group of patients who have not gotten 15 lymph nodes, then I think you'll be able to see if there is in fact a survival advantage or not.
See that in frequency, and is pancreatic decreasing?
I think the gastric cancer actually is probably maybe decreasing slightly in its frequency, but pancreatic cancer definitely is increasing, yes. That we have seen.
I can recall when I was a resident that there were several articles came out the same year that coffee led to an increased incidence of pancreatic cancer. Everybody was horrified and people quit drinking coffee. That didn't last very long. Any other questions for the audience? If not, we will adjourn. We want to again thank all of our remote sites. Tell Dr. Simpson we missed him tonight out in Eastland. Our next lecture is going to be in December. Watch your email. A new member, Dr. Noel Cloven, will be presenting an interesting talk on the morcellation controversy. And that is an issue in GYN oncology, and I think in other fields as well. So the morcellation controversy in December, we have a full schedule. So we will adjourn right now, and then